imaging come into this whole process?
Right. So MRI now is really being used to better stratify patients who need biopsy. And so, you know, if somebody has an elevated PSA, historically, depending on their PSA level, the chance of having a positive biopsy was on the order of, you know, 10 to 15%. So that means we biopsied everybody with a PSA in that above 4 range. You know, 80% of patients have negative biopsies. So what MRI is going to allow us to do, it's potentially going to allow us to instead of you getting a biopsy first, maybe look at the MRI and we get a directed biopsy. So there's 2 reasons you might have a negative biopsy. Number 1, there's no cancer in your prostate, or number 2, you missed the cancer, right? So with MRI, you can, if you've got an area of concern, then you can do what's called an MRI guided biopsy instead of just a random biopsy. So when we do biopsies now, or historically, it's you put you know, you did the 12 cores or 16 cores based on the location of the needle you put, but it wasn't directed by anything. Now with MRI, you can have a direction for that needle, and the rate of positive biopsies is going to go up because you're going to do fewer biopsies that are negative. Now, MRI has limitations, like all imaging. There's a detection sensitivity, and it's you know, it's not going to show you every cancer, but it's going to show you a lot of the cancers. But I think it's really the trend with regard to biopsy. I think more and more men are going to get MRIs either after their first biopsy or before their first biopsy. Unfortunately, a lot of the insurance companies in the U.S. will not pay for an MRI unless you have a diagnosis of prostate cancer or you've had at least 1 negative biopsy. So using it for the initial biopsy is, I think, where it's going to go, but we're not quite there yet from a payer standpoint. Yes?
I'm new to this PSA, but does a high PSA necessarily represent cancer, period?
No, not always. Most of the time it doesn't represent cancer. Now, there's high and then there's high. So high in broad terms is, say, if you're, you know, we used to use 4 as kind of a cutoff. That's really probably not a good number because it's really the rate of rise of your PSA, not the actual number that makes the difference. But some guys will have very large prostates and they'll have a PSA of 10 to 15 in that range. That's normal. If you walk with a PSA of 50, that's not an enlarged prostate. That's prostate cancer. So when I say high, if you walk in with, I would say 20 or above, you should get a biopsy for sure. I mean, you should get a biopsy above 10 in my opinion, but I would say that the chance of this being an enlarged prostate goes way down when you get above 20. You know, then we're really talking a higher chance of being a prostate cancer. But to answer your question, not every elevated PSA is cancer. Yeah. Yes?
I don't want to put you on the spot, but I will. So I'm actually scheduled to have a robotic surgery up in Swedish by Kaiser on Monday. Mm-hmm. And the question I have is experience. And I trust my surgeon, but he doesn't have a lot of experience. And I said, you know, this would be his 25th or 26th. And the way he described it to me is, I was trained right out of school to do this. This is how I was trained from the start. So he felt it was different than somebody who had learned another procedure and then had to be retrained to do that. And I wanted to get your thought on that.
Maybe we go offline on this one now.
That's all right if you want to talk to me afterwards.
No, I mean, I don't really get what he's trying to say with regard to learn another procedure and then come into this. You know, when you're flying a plane, your hours are when you're the pilot, not when you're the co-pilot, so to speak. So, you know, I don't know what it means, but he might be, you know, he might have. So let me say this. So there's learning curves for everyone,
right?
And the reason to get training is to shorten your learning curve, right? So that so my learning curve was longer than you know, I've trained 17 fellows now. Their learning curves were shorter than mine because they learned from me, right? So depending on who trained that person, mm-hmm. or how many people trained that person, you know, that his learning curve could be he or she. It could be a she. That learning curve could be much shorter, and where they are experience-wise at 25 may not be where I was at 25.
Right.
Okay, so I can't say that, you know.
Well, I know you can't.
What he's saying is, you know, not accurate or whatever. I would say in general. It's when you're, when you're running the show where you're, where you gain your experience. And I think you can learn only so much from people. And I use this commonly, I do a lot of teaching, and that's another thing that I do a lot of. And I always have this saying that experience is learning from your own mistakes, and education is learning from the mistakes of others, okay? And that's really that's the reality of life. People are making mistakes every day, every moment.
Sure.
And you're learning from those either on your own or somebody else's mistakes. So, again, depending on how many mistakes his mentors had and where they were at their learning curve,
So I'm understanding, he says he has a second surgeon there with him who's much more experienced than
Right.
him.
So you want that one.
Pardon me?
You want the second surgeon.
Well, he's there assisting in that. I mean, I'm a retired healthcare person, so I know,
Yeah.
I'm familiar with this.
No, this is the reality of medicine.
It's the reality of medicine,
yeah.
and I know, I've trained students myself, and so, but I really trust him, and I put the question to him, and
Yeah.
I think I got an honest answer.
Well, and trust is everything.
Yeah.
Like I said, trust is very important. I'm not sure it trumps
But
a huge amount of experience, but I think it's still very important.
But I realize that. I realize that and accept it, but I just sort of wanted to get your take on it.
Yeah, well, good luck.
So it would be more interesting to do 3,000, but I'm a Kaiser patient.
Right. Yeah, I hear you. No, I understand. There are rules. Yeah, we follow the rules. Yes,
Your field is robotics, is that?
that's right.
So what is the difference, or describe the procedure for robotic versus, is it better, safer, more reliable, less side effects? Tell us about it.
Yeah, sure. That's my easy talk. So we're going to compare it to, you want to compare it to open surgery? Is that our comparison?
Well, I don't know anything about any of it.
Okay, well, good. So I'll give you the quick, tutorial. So before the robot and before laparoscopy, everybody was opened up like a fish from their belly button down to their pubic bone. And we put a retractor in so we could see, and you would work in this giant hole, because the pelvis is shaped like a funnel. Very narrow on the bottom, it opens up on top, and it's a very, very tight space. The prostate sits in the bottom of that funnel. So if you can imagine, a walnut or a plum sitting in the bottom of a funnel, that's what you're doing. And there's very little space. But this is where the operation was started, and it was perfected, and in certain hands it was done very, very well. But I would say in the majority of hands, it was not done so well. And we know that because when you look at the literature and the data before the robot, and we're talking about some of the best people publishing their results, the average blood loss from a very famous surgeon was 1,600 cc's. That's the average. Okay? That means there were people well above that and people below that. But open surgery was a very bloody operation. It was absolutely common for people to bank 2 units of blood of their own blood prior to the surgery because they were going to get that blood back. That's called autologous transfusion. And they did that because it was a bloody operation. So, and again, there were a few people that did it well, but it was hard because of visibility. It was hard because depending on the size of the prostate, there was more or less space in there. But it was the way we started the procedure. It's how we learned it. When the robot came along, we were no longer working in a hole. There was still a funnel, but instead of us being out here looking in the funnel, we were inside the funnel. Our eyes were that far from the prostate. And the light, which was a big deal, the light was not coming from the back of our head. It was that far. It was coming from the tip of our eyes. And the visibility made all the difference in the world. In addition to that, the robot also gave us the ability to move instruments in more, what we call degrees of freedom, or more spatially, in more angles. And so you could work in these tight spaces much easier than you could with standard open instruments or laparoscopic instruments, which were very straight. So, and for the surgeon, instead of standing up to do the surgery, you were sitting down. So for the surgeon, they were more comfortable, which means they were less distracted by back pain, neck pain, and so they were more focused. And they're immersed. So this view is 3D. So you're immersed in this 3D view, so you see depth, you see magnification, 10 to 15x. So it's not just that you were close to it, but it was magnified. So all these benefits meant that we were able to change the operation. So I'd say the major benefit of robotic surgery from a public health standpoint is that more surgeons can do a better operation than open surgeons can do a better operation. So there's more people, I'm not saying there's people that still don't do bad robotic surgery, there are. But there's more surgeons who can do a better operation, maybe not the best operation, than there were open surgeons who could do a better operation. There were some very good open surgeons, but they were a handful, 5, 6, 7 in the country. Now, there's a lot of people who do a very good operation. Now, there's still degrees of difference, but that's the major, I would say, the public health benefit of the robot. What's the specifics? Compared to open surgery, there's definitely less blood loss. So, I haven't transfused a patient in 11 years, okay? And I'm not talking about, we don't set autologous blood aside. We never do that. That would be a huge waste of resources, okay? I mean, giving somebody extra blood outside, 11 years ago I did that. The outcomes with regard to urinary control, getting your continence back, erectile function, and cancer control, in my hands, are as good as the best open surgeons. And I am not one of those open surgeons. You know, I've done maybe as much as they have now, but these results were actually good, you know, 2,000 procedures ago. So the learning curve, or the ability to get to a very good place in the operation, was actually much shorter with the robot than it was with open surgery. The recovery that patients experience is much different than the open surgery. So instead of having we would routinely leave the catheter in for 2 to 3 weeks with open surgery because it took that long for the anastomosis to heal. With the robotic approach, it's 6 to 7 days, 8 days, depending on, you know, your comfort level. Patients go home the next day with robotic surgery. It was 2 or 3 days in the hospital. Open, not a big deal. The major recovery was outside the hospital, the fatigue. Because when you drop your blood level, when you lose blood, you have what's called anemia. Yeah. Anemia makes you tired. And anemia is what keeps people from recovering quickly. In my patients, they don't lose that kind of blood. They don't have anemia. They're back to their activities sooner. Less pain medication use. So they don't use the narcotics, which cause all the side effects, the constipation, decreased appetite, nausea. We don't have to use the amount of narcotics that they did with open surgery because the pain is less.
How do you go in?
What's that?
How do you go in with the robotic?
How do we get in? Well, we put the incisions through the abdomen, and we create space in the abdomen with carbon dioxide gas. So if you just put what we call a port into the abdomen, you can't see anything because between the abdominal wall and your bowels, there's no space. But we put carbon dioxide gas with a small needle into the abdomen, and that creates a space for us. And then we can put our ports into that space, and we work in that space. So that carbon dioxide stays in the abdomen the whole time. We have a pump that's pumping carbon dioxide gas inside the abdomen the entire time. So that's how we create enough space to work and to see, but still keep the abdomen closed. Keeping it closed has benefits because you have less pain, your things don't dry out because the humidity stays the same inside. So when the bowels have the same humidity, they heal faster, the bowels wake up quicker. That's how we that's how we create enough space. It's carbon dioxide gas. So right now, 85% of robotic surgery, of prostate cancer surgeries done in this country are done robotically. 85%. Yeah. Yes.
And not to expose myself, but if you want to see my scars, I mean, they're tiny. Comparative to what, you know, because that's
Show and tell, show and tell.
But I mean, you know, you're asked a very good question: is how do you get there? And it's.
How do we get the prostate out? So we want the prostate to come out whole because we want it analyzed just like you would with open surgery. The margins and where the cancer is in relation to the outside of the prostate is a very important predictor of the cancer coming back. So when the prostate's freed up, we place it in a bag. It looks like a butterfly net. And on the top of the butterfly net is a purse string that cinches that net down. This is very thick plastic. And then we pull because we're compressing the prostate a little bit, we can pull it through a very small incision. Now we do make the incision we take out the prostate a little larger. So your incision above the belly button is a little larger, okay, than the other ones. That's where we take the prostate out. But the reason you don't have a lot of pain with that incision is because we don't have a retractor in that incision. So a lot of the pain for open surgery comes because they have to really reef on that retractor to make enough space. And you have that on there for 3 or 4 hours, you know, that hurts. So that's how we get the prostate out, sorry.
Does robotic help you see the very fine nerves down there? We had one urologist said that, I guess, I don't know what type of operation, it's hard for him to even see them, they're that fine.
Right, so you can't see the nerves.
You can't.
The nerves run with blood vessels. They run as a complex.
Okay.
It's called the neurovascular bundle. So nerves, vascular means vessels, and then the bundle is one area. So you can't see the nerves individually, but they're in with the blood vessels, and they're covered by fat, and so, but it's a complex, and we know where it is, but we can see the nerve bundle very well. And what we can really see, which is important, is the interface between the prostate and that neurovascular bundle. That's what's important, is that when we separate and spare the nerve, we want to see that interface. That's what's really important. But the individual nerves, we don't want to see them actually. We'd like them to be nice and covered. And with the blood vessels and not exposed.
So
Yes.
your chance of doing damage to them is less.
Yes, if done properly, if you don't use cautery, if you are careful with how much traction you put on the nerves, you can do a very good nerve sparing and preserve erectile function, which doesn't have a lot to do with urinary function. There's some studies that say it does, but some that say it doesn't. But in general, sparing the nerves does not really impact urinary control as much as you would think. Yes, sir.
You say with a radical, they do a up and down,
The open, yeah, the open.
not in all cases.
You might, well, you had it open?
Yes.
Okay, I would say the majority of people do it open.
It goes this way.
Yeah.
The only thing that I noticed about it was that my recovery time, now about the blood thing, nobody even mentioned that to me.
Mhm.
But the recovery time was, I tried to go golfing at 6 weeks, and that was a big mistake. The recovery time is quite a bit longer.
Yeah.
But I want to can I back up a little bit into
Sure.
this thing about what's the thinking now on PSA? You said that it was kind of put down with a group of people who
Right.
don't know. What
So
was
the task
official-
force, yeah, so the task force, just so you understand, was a government organization that actually looks at how you prevent disease. And so they've been people that have made decisions about mammography for breast cancer, colon screening for colon cancer. They look at the literature and make recommendations on that. So this is a United States Preventive Task Force. They're a part of our, the health government. So they came out with this recommendation in 2012 that we shouldn't be doing PSAs. Recently, I think last year, they came out with they didn't fully retract it, but they said in certain populations of men, you could do PSA on a periodic basis. So they've backed off a little bit, but there's still the problem. And the problem is, I'm a urologist, so I understand this pretty well, but the primary care doctors are getting mixed messages all the time, and they get confused. And they're the ones in the trenches that are making decisions about who's getting a PSA and who's not getting a PSA. And they're very confused because they're getting messages saying we shouldn't do this. And so there's a lot of primary care docs that don't do it unless somebody asks. And so I see people all the time. They get their first PSA and it's 15 or it's 25.
What is the common, how would I put this, what are they saying you should do then?
Well, depending on your family history, so if you have a family history of prostate cancer or African American race, these are two risk factors for prostate cancer, you can start doing PSAs, say around 50.
So they've taken what they're saying is there's no hard line on either way.
Well, they haven't said it's a great test. They didn't come out and say that, okay? They gave it was a D rating, and now it's a C rating, okay? So they've improved it a little bit, but I think they've allowed more wiggle room with regard to doing PSA. Now again, this is a government group. They don't. It's not a law. Nobody's going to jail if you get a PSA. So it's just a recommendation. But I think what it does is it creates confusion in the medical community about the role of PSA.
I'd like to back up to one more thing that you said. You were talking about the prostate cancer coming through the female.
Well, the genetic.
Yes.
Yeah, the BRCA gene, the BRCA gene.
Yeah,
Yes.
that has happened in our family because both grandfathers lived almost to 90, never had any cancer, prostate cancer, but all their sons did.
Yeah, so there's a lot of genetic testing being done now in patients with prostate cancer to try and figure out, where it's coming from. So we're starting to understand these links, which we didn't even understand, 3 or 4 years
So I
ago.
thought at that time, that's crazy, but
Yeah.
what you're saying now, that's being recognized as something that's very viable.
Yeah, it is.
Oh, okay,
Yeah,
yeah.
it's important. Yes.
My paternal grandfather died of prostate cancer. Of course, I have it too. So what risk does that give your brother?
Your brother has a high risk. He has a family history, so he should be tested, no question.
Okay.
So first-degree relatives, brothers, if your son should be tested, and because those are first-degree relatives, and they have a high chance of having the disease.
And the funny part is he's a pathologist, and he does want to get tested.
Mm.
So, and
You need to look
tell
at
us
prostate
about,
cancer.
I know. The new Da Vinci machine, is that much better than the old one? The one who's come out?
Well, I
think there's supposed to be a new.
Yeah, so the newest one is something called the single port robot. So when we do this, getting back to the procedure, when we do this robotically, I use 5 incisions, one above the belly button on 2 on either side. 4 of those are for the robot. 1 is for the robotic camera, and 3 are for robotic arms that I actually control. And then I have 1 for my assistant at the bedside. So I have an assistant who's there with suction, bringing needles in, creating exposure for me. So I have a total of 5 incisions. The Da Vinci single port actually puts all those 4 robotic incisions into one larger incision, but it's one access. So the incision, instead of multiple, is larger, but everything is kind of compressed into one. And the arms are actually work quite well. It just got approved recently, and I actually have had the opportunity to do some testing on it at Intuitive, and I think it's got promise, but I'm not sure it's going to make a difference for patients with prostate cancer. And the reason I say that is I've done a lot of single port surgery. I do single port surgery now with the multi-arm robot, so you can actually put all the multi-arms into one hole. It's quite difficult, but I do that actually not for prostate cancer, but for conditions of the kidney in young women who are cosmetically minded and they don't want multiple incisions. So I'll go through their belly button with the robot and put 4 or 5, I'll put 3 or 4 arms in there and do the procedure, and it's successful. And we do it for blockage of the kidney. The reality is they have the same amount of pain than the ones with multiple incisions on the belly. The real benefit is just the cosmetic benefit. So for, a 65-year-old male with a hairy belly, I don't think he cares, if he has 1 incision or if he has 5 incisions, right? You can't see them, right?
Do you wear a goggle? Is that how you're viewing, or screens?
No. So you sit in a console. Yeah, I should have brought my talk. But anyway, you sit in a console, and it's like you're sitting down in a chair. I sit in a chair, and this console, it's got a viewfinder right here. Do you remember when you were a kid, the VHF viewfinder, that thing that you would look into, and it would give you that depth, that thing? That's exactly the way this looks. You're looking at this thing, and you see this incredible depth of the tissues, and it's real. It's not like a cartoon. It's absolutely real. And that depth really gives you the detail you need to do very precise procedures.
How far are you from the patient?
About 10 feet away.
10 feet?
The patient's right there, and I'm connected by a wire to the robot. And so all my hand movements, the robot doesn't do anything. So it's, in the true sense of a robot, it's not truly a robot. A robot is autonomous.
Yeah.
This is not autonomous. This is a controlled device. It's a tool. And we call it a robot because that's the term that's been applied, but in reality, it's not truly a robot.
But does that programming in it have anything in it keep you from going certain places?
Well, it has some very important engineering, which is kind of what you're talking about.
Okay.
What it has, one of the biggest benefits of it that I didn't touch on because it's complicated, is that there's something called scaling in this robot. So what does this mean? So when I'm not at the bedside and I'm moving these instruments, I don't really know kind of what's going on inside. So the engineer said, you know what, I don't want there to be big movements in the patient if somebody is sitting somewhere else. So what they did is they scaled down the movements, which means if I made a big movement at the console, and by the way, I control the robotic instruments with these little finger, we call them cots, they're clutches, and they basically are like this. And so when I do this, my instruments open and close. When I do this, the instruments turn. When I bend my wrist, the instrument bends at the wrist.
Wow.
It's very Intuitive, the name of the company, yeah. But that's the way these instruments work, and it's absolutely more precise than anything out there.
Huh.
But the scaling thing is very important. Because what scaling does, it means that if I make a big movement, at the console, it's scaled down, and the ratio could be 5:1, so I have to move 5 centimeters to move 1 centimeter in the body,
Okay.
or 2:1, 2 centimeters to move 1 centimeter, or there's no scaling. So no scaling means you can move the instruments faster, but you have to be very experienced to use that. So I still use 2:1 because I like the safety. What's the other benefit of scaling? This is the side benefit. When I did open surgery, or anybody did open surgery, or even laparoscopic surgery, when you move an instrument with your hand, when you do something intentional, there's a little tremor, okay? I don't know how many of you guys do anything like fine work or whatever, but when you do something with an instrument and you try and do something, your hand moves a little bit, okay? It shakes a tiny bit. It's called an intention tremor.
Huh.
The robot dampens that and it negates it, it's gone. It makes the movements fluid, it makes the movements tremor-free, and you are better than you ever were with any instrument you've used before. It's amazing. That's what scaling does.
Yeah, I have a question,
Sure.
since we're in the world of mechanics. Does your big toy have its own independent power supply? There's a reason why I'll say that, in case you have a perfect storm, a little earthquake,
Right.
the power grid goes down, you get
Right.
a spike or a surge in
Right.
your AC line. Now, some fancy computer systems will have their own UPS, but still, when UPS takes over, you still have a break, a millisecond, a microsecond break. That confuse your big toy to disrupt your acute performance.
Right. So we've had power outages in our hospital, okay, it happens.
Right.
And so at most hospitals, the downtime from being on mainline to generator is like less than a second. It's a half second.
Yeah.
You can see something happen, but the power's still on, okay? We have not seen that affect the robot. We've had that happen. So I don't know if it has its own power supply, I don't know if I can answer your question, but we've had that test, we've had the unfortunate test, and we haven't lost the robot.
Yeah, I used to work with UPS systems with computers, and sometimes the computer would have to reboot. I didn't know if your robotic was going to be really sensitive to any glitches, since you're working with little fingers and all that you'd have to start over again, and time is an element, even with robotic surgery, that you
It does 30 minutes.
won't in the body so long.
No problem so far.
Good. If I ever need yours to come, then I can
Just up at
reduce that
27.
anxiety, kind of about electronics.
Okay,
So
thank
how
you.
long is it typical surgery?
Well, it depends. If we're doing standard nerve sparing without lymph nodes, it's about 2 hours. With nodes, it's about 3 hours, sometimes longer, depending on the size of the prostate and the size of the patient. Bigger patients take longer. They're more complicated. Also, the pelvis, the size of the pelvis is also a challenge. And pelvises vary tremendously. Some guys have very narrow pelvises, very hard to do a surgery there. Some other patients have wider pelvises, very easy to get inside. Yes, question?
The PSA, but the government get involved, and is that something doing unnecessary biopsies sometimes, doing too many of them? And are those biopsies doing harm doing the biopsies?
Well, the potential harm of a biopsy is infection, and there's a small risk of bleeding, but bleeding is actually a minimal risk. Very few people have a lot of bleeding, but it's really sepsis. People getting severe infections. That's pretty much alleviated if you give the correct antibiotics. For a while, people were not giving the correct antibiotics. There was a resistant strain of E. coli that was resistant to a commonly used antibiotic, and so there were a lot of infections. I don't think the PSA was really about biopsy. It was really about the over-treatment. Once you got the diagnosis, people were getting treated. They use biopsy as one of their leverages, but that to me is a minimal risk compared to taking somebody's prostate out.
I feel like it's overtreated in other areas, so I was curious.
Yeah.
Putting an infection to the side. If a patient has really thin blood, like me, and it's not because of medications, it's just born that way, do those particular percentage of patients leak blood to the urethra after a significant biopsy?
Yeah, a lot.